Hello, everyone. You can wait a few minutes for all the participants to join in. We have nearly 150 people who registered for this webinar, and it is quite early for some of them as well, and quite late for a few other parts of the world. So just waiting for everybody to get settled in. Okay, so hello everyone once again. Welcome to the fourth TBPPM webinar of this year. Today we are going to be learning about the role of private sector in building resilient TB health systems with a specific focus on being prepared for the pandemic. We have a stellar panel of experts today who will be sharing insights on this topic. Before we proceed, a couple of logistical announcements. This is a 90-minute session, so please use the Q&A function of the webinar. If you have any questions, please post them on the Q&A section of the webinar, and we will try to call on you, or we will answer it directly on the Q&A session. The session is also being recorded and live streamed on our YouTube channel. You can also turn on the subtitles for your use. We will be sharing the webinar report beginning next week on our website, and also have a discussion on this on our TBPPM Learning Network website. So if you are not part of the TBPPM Learning Network, please sign up at www.tbppm.org. So to moderate today's session and introduce the topic, we have with us Dr. Charity Ogamenka. Dr. Charity Ogamenka is an assistant professor at the School of Public Health Sciences in University of Waterloo. Her work predominantly focuses on the impact of COVID-19 on the care-seeking patterns of people with TB, especially in the private sector in high TB burden countries. Amidst the other skill sets, Dr. Menka is widely recognized for her mixed methods research skills. So she's the perfect person to moderate today's session. Further details about Charity can be found on her TBPPM Learning Network profile. So you can access all the panelists and their bios profile on the Learning Network. So I would like to now invite Charity to introduce the topic and the panelists. Over to you, Charity.
Yeah, thank you, Joel, and the TBPPM Learning Network for hosting this webinar. And I want to thank everyone for joining us today as we discuss engaging the private sector for TB system resilience and pandemic preparedness. The unprecedented challenges brought by the COVID-19 pandemic underscore the urgency for all of us to collectively reflect on our preparedness, or the preparedness of the healthcare systems for future global crises. So as we witnessed during the pandemic, the fear of infection led so many people to avoid, the public sector. And so we are preferring to seek care with private sector providers that were closer to their houses because of all of the restrictions, and also because of fear of infections and all of that. And we saw governments all over the world beginning to engage with the private sector in new ways to make sure that services for other health issues were not neglected as the public sector struggled to control the pandemic. So today we're going to discuss some of the findings from our own learnings from some of the research that we have done. We'll highlight some of the studies, some of our panelists will highlight the studies that we have done. Particularly, I want to, mention the COVID study. This is the COVID-19 effects on TB services in the private sector study. This was conducted by the McGill International TB Center, Georgetown University, and University of Waterloo. And the study aimed to assess the landscape of the private healthcare sector during the pandemic and in 3 high TB burden countries, Nigeria, Indonesia, and India. It focused on the quality of care, patient pathways to accessing care, impact of the pandemic, and then the provider adaptations to these disruptions. So join us today as we examine the lessons from these experiences and then discuss some of our thoughts on how, the health system can continue to prepare for future global health crisis. I have a wonderful panel, a very beautiful panel of experts with me today, and it's my pleasure to introduce everyone that is here, starting with Monica. Hannah Monica Dias leads the work at the World Health Organization Global Tuberculosis Program on advancing multi-sectoral engagement and accountability. And particularly, she focuses on engaging private sectors to address key drivers of the TB pandemic. She coordinates the WHO flagship initiative on ending TB, and that focuses on accelerating universal access to quality TB prevention and care. Right, and so it's a pleasure to have her today. Monica is an expert, and we're really glad to have that she spent time out of her day to discuss with us today. She also works on HIV and trade at the International Trade Center non-profit hospital in Mumbai. She holds several master's degrees, including in business administration and international health policy. I also want to introduce Victoria Haldane. She's an epidemiologist working with the Public Health Agency of Canada. She has worked on pandemic preparedness and response with organizations including the WHO, World Bank, and International Panel for Pandemic Preparedness and Response. Her prior research at the University of Toronto explored health system resilience, as well as interventions to strengthen the circle of care around people living with TB in Tibet. We've used Victoria's work a lot in some of our own work, and we're really inspired by some of what she has done. I also want to introduce Laura Jane Brubache. She's an adjunct assistant professor and SHERP postdoctoral research fellow at the School of Public Health Sciences with the University of Waterloo. She's interested in the use of community-based qualitative methodologies for applied health research. Laura Jane worked previously as postdoc with the UBC, University of British Columbia Health Systems Response to COVID-19 Research Group, and for the Institute of Mental Health Policy and Research. She currently works in the Global Health Research Group at the University of Waterloo. Then I also want to introduce Dr. Obioma Chijoke Akaniro. She's a pediatrician, public health practitioner and scientist. She's presently the M&E manager at the National TB Program in Nigeria, and then the Deputy Director in the Federal Ministry of Health. She serves as the Secretary, TB Operations and Research Task Force, and she's involved in public health research both in and outside Nigeria. She joins in conceptualizing, operationalizing, monitoring, and evaluating strategies in Nigeria TB program. And finally, but not the least, I want to introduce Vaishali Venu. She's the Director of Health for an organization called Doctors for You, which mainly works on health, skill development, and disaster risk management. COVID-19 being a health pandemic that her team works on within the entire country to provide support for health systems. Apart from setting up the COVID care makeshift hospitals and treating patients for COVID-19, one of the main activities has been for the team to ensure continuity of primary health care for people, particularly maternal and child health in India. So with great pleasure, I'm happy to work with these panelists to discuss this topic today. So without much ado, I'll hand you over to Monica Dias to give us an introduction and to an overview of the work at the WHO.
Thanks so much, Charity. I'm just trying to pull up my slides. Warm greetings to the fellow panelists and also to all the attendees of this this webinar. So very briefly, my presentation is going to focus more on the TB front of the response. Let me first check if I can, may I please check if it's visible, if you can just confirm. Joel, Charity, is my slides visible?
No, not yet, Monica. You're not able to see a slide.
Okay, sorry. Wait, this is, hold on, one more time. Is it visible now?
Yes.
Yeah, we see it
Yes.
in the regular mode.
Yeah. Okay, does this work now?
Yeah, perfect. Okay.
Okay, so the focus of my presentation is going to be mainly on ensuring a resilient global TB response in alignment with the pandemic preparedness agenda, which I know other panelists here are more equipped to speak on. But this is a very critical time for the World Health Organization, where in the lead up to the World Health Assembly, and there is a pandemic accord in discussion right now, which is really critical, and there's a lot of work being done behind the scenes in the lead up to it. And it's based on our experience, it's really important to make sure that we continue to keep the spotlight, learning lessons from what we faced, especially in 2020 and 2021 on the COVID-19 pandemic. So again, putting everything back in context and coming at it from the angle of the TB response, just to remind everyone, TB remains one of the top infectious killers, especially those who join from outside the TB community. Still a very significant burden, both of TB and drug-resistant TB, and of TB infection, which infects a quarter of the world's population. Now, if you see the graph that I've posted there, this is older data, but you can see very clearly that the COVID-19 pandemic caused a huge dent in progress in the response. And you can see how the notifications really dip down there. And if you go further into countries, especially here, you can see also the impact both on notifications, or, you know, notifications are, of course, a proxy for people having access to care. And here you see again, very clearly in India, for instance, a massive drop both in public and in private sector access to care. Indonesia, similarly, this is again old data. Again, you could see that there was impact back then. If you look at China, if you look globally, South Africa, looking again at diagnosis around that time of the COVID pandemic, you can see huge drops. Likewise, in access to TB preventive treatment, in TPT, again, drops. So overall, there were disruptions, and we know this, especially for communicable diseases. And for those of you who've been part of the PPM working group discussions that have been held over the past few years that went virtual, especially during the COVID-19 pandemic, you may have heard some of the stories, some of the experiences that came through. And I think also during the PPM Learning Network discussions, that during the pandemic, there was a huge compromise of access to services, and even more so in the private sector. And I'll let Petra and team, and I'm sure Charity will go into this as well on the private sector itself. And here, if this is some of the work that was done by WHO to look again at notifications from public and private sector as reported to WHO, and you can again see huge drops, especially from the private sector. The drops, a big contribution was the drop in private sector notifications. I think with the exception of Nigeria, practically all countries, you could see you know, drops in access to care. TB deaths increased for the first time. So just giving you some of the, we call it historical perspective, but I think that's important for us to build a case of why, as we're talking about pandemic prevention, preparedness and response, that it's important that we also ensure in our quest for health for all and universal access to care, that that care is maintained across. Now, this is again a very quick snapshot of, you know, some work, some analysis that was done, data that was collected. Again, you could see across countries that health service availability was impacted, resources for TB, including staff, funding, machines such as for expert, were reallocated. But there were a few other elements that came through which were positive. For instance, there was a huge scale up in use of digital technologies, community or home-based care. So things did change also for the positive. There was an increase in availability of expert machines that were used later on. WHO put out a lot of guidance around this time to combat or to ensure continuity of services during the pandemic, and that's a quick snapshot. And here is some of the way that we changed how we were managing the TB response at that time, with more people-centered care, looking at infection control, innovative measures to minimize healthcare visits, the use of digital technologies, leveraging capacity. All of these different elements were really strengthened and used. And it really brought home the fact that investing in the TB response strengthens pandemic prevention, preparedness, and response by strengthening public health measures, for including PHC and TB care to prevent, prepare, and respond. The examples, of course, encompass surveillance, information system, lab capacity, provider capacity, and of course, the leveraging of TB molecular tests, contact tracing platforms. The TB staff were used extensively, and all of this really very clearly shows the linkages therein. And this was also highlighted last year at the UN high-level meetings for TB, for pandemic preparedness and response, and on UHC. So some of the lessons learned, I would say, from the pandemic include that, there's a lot of capacity from TB programs that can be leveraged, as we saw with the COVID-19 response, that could be leveraged, that could be built in as we look at the pandemic response. Private sector has a major role to play in pushing up notifications, ensuring continuity of care, and this is aligned with overall WHO's work on universal health coverage and private sector engagement. The technical advice for TB, when you look at other respiratory diseases, when you're looking at pandemics, normally looking at those respiratory infections linked to it, the technical advice across infection control, lab biosafety, treatments, the innovations, etc., can be leveraged across. And here is an example, for instance, about infection control and biosafety that were used for COVID-19. Likewise, the platforms, etc. And also the importance of collecting, interpreting critical information, and monitoring of best practices. This has been key. Even for TB, we were able to push countries into monthly reporting, real-time reporting, and this was also beneficial that we've been able to sustain. And we could see very clearly, following all of this and maintain and ramping up efforts, I think as a community, both across public sector and private sector, last year we were able to see an uptick, and the highest figure recorded of people reached with TB care. And we know that this year it's gone even higher. When the report comes out in October or November this year, you will see that the number has gone up quite significantly. And this is because of a joint effort across sectors, leveraging on lessons and building on the successes of the response, the re-energization of programs following the pandemic, and building back stronger. This has really helped, and we are seeing that the positive elements of it. And this has been further bolstered by the commitments that we have. You all know of the various commitments. We have a DG flagship initiative, so highest level prioritization of TB by our Director General, and of course the commitments made in the political declaration of the UN high-level meeting by world leaders also give further impetus to the work on bolstering the TB response, and very clearly one of the commitment states to build on the interlinkages across global health agendas of TB, pandemic preparedness and response as part of efforts to move ahead on this, also reinforcing the central role of WHO in all of this. So in essence, I mean, there's a lot of work happening. As I started off this presentation, I did mention that there's a lot of work happening overall in WHO on pandemic preparedness and response. We have, for instance, a new initiative, Preparedness and Resilience, for emerging threats called PrEP, which means ready in French, for instance. And you can see that there's, as World Health Organization as a whole, working with countries, there's a lot of work that's moved ahead on pandemic planning, with several countries getting on board with updating preparedness plans, increasing connectivity, and dedicating the necessary resources. And the TB response has a role to play within this, both across public sectors, as well as having private healthcare providers building on those lessons learned. So it's really important to have it there. And as we look forward to what comes out of the World Health Assembly negotiations, whatever emerges in terms of the pandemic treaty, the accord, as we look at operationalizing this, and looking at translating it into action, ensuring continuity of TB services, along with, of course, other healthcare services, will be vital as part of the overarching response to ensure that no one is left behind. So I'll pause there. Thank you very much for this opportunity.
Thank you, Monica, for sharing some of what the WHO is doing. We appreciate the work of the WHO in coordinating and leading some of this work, and also for the guidance documents that have been very helpful for the countries and for researchers as well. Now we'll move on to Victoria to share some of the lessons that she has gleaned from 28 countries on pandemic preparedness and resilience. Over to you, Victoria.
Perfect. Thank you so much, Charity. Here, I will share my screen. I will make it. How's that looking? Good? Okay, perfect. Well, good morning, good afternoon, and good evening. And thank you very much for the kind introduction, Charity. I'm also a TB researcher when I'm not doing pandemic preparedness and response work. So this is all very close to my heart, and I'm really thankful for the opportunity to share with you and to learn from the other participants today. So during the pandemic, I was a part of a team of researchers from around the world that was convened by the Independent Panel for Pandemic Preparedness and Response. And I'll be sharing some of the lessons that we learned when we were analyzing national responses to the COVID-19 pandemic from 28 countries in 2020 and 2021. So here we go. My talk today will be structured around 3 key lessons. So the first is the importance of strengthening the basics of public health. The second is that resilient health systems matter. And the third is that we really need to transform how we approach preparedness and response for outbreaks, epidemics, and pandemics. The data informing my talk today, it's from that work I mentioned, commissioned by the Independent Panel. And the Independent Panel was one of the groups tasked with evaluating the global COVID-19 response and providing feedback on it. The 28 countries that we drew from, they were selected on the 6th of November, 2020, which seems like just yesterday, but also a lifetime ago, right? And I bring that up so that you note that this data really does reflect a slice of time from the start of the pandemic to around early 2021. So I'm sure if we redid this, we could draw even deeper conclusions with what we know now. So we conducted a living literature review, and we drew on emerging published literature, gray literature, policy documents that were available at the time, as well as media. We also had government submissions to a survey that was put out by the Independent Panel, which also held roundtable discussions, and then our analysis was validated by experts. So I will be drawing on some of the work that we published in both Nature Medicine and the series we put out in the BMJ. So I have links to these at the end of my slides, and my slides will be available in case you want to dive into some of our readings. All right, so let's go into the first of the three key lessons, and that's on strengthening public health systems, and that we really need to invest in and support the basic functions of public health. In our work analyzing the responses from across 28 countries, we found that at that time, effective public health responses to the COVID-19 pandemic were those that focused early on in the core components that are pretty standard to any outbreak response. So that's identifying the pathogen, those who have been exposed to it or who are symptomatic, surveillance activities to monitor its spread, efforts to break those chains of transmission in communities, risk communication and community engagement, supporting the health workforce and the public health workforce who are responding to the emergency, and ensuring that infrastructures and systems are in place to support the response. So when you put it all together, you can kind of see how all of these elements work together in a system, which I'm sure is very familiar to everybody here. So we also found that pandemic preparedness and response requires foundational public health functions that are localized, so they're engaged in communities and able to sustain tailored responses. They're responsive themselves, that the public health response was supported and there was capacity built during the pandemic, that they're integrated, so data systems were brought together so that the health data and information could then be used for making public health decisions, and that they centered on equity. These responses were equitable and they held values that related to human rights, equity, and community engagement at their core. So since we're talking about public-private partnerships, I drew out some of the considerations that were flagged in our research when considering the public-private aspect of strengthening the foundations of public health. And that's relating to ensuring that all parts of the health system, including private care providers, were linked to public health response activities so that there was a full epidemiological picture. And then some countries worked closely with the private sector during the pandemic to carry out essential public health functions related to emergency response. So for example, relying on short-term contract workers to carry out contact tracing in communities. And coming out of the pandemic, there was a need to consider what are the best practices for ensuring that training and supports reach all workers that are onboarded during a pandemic. And, or put another way, what are the best practices for engaging with the private sector in this way during a health emergency? And this goes a little bit beyond the private health sector, but we also saw with COVID-19 a big draw on data from consumers with big companies as intermediaries, and preparedness against future pandemics would require a consideration of how to better use these for the public health response. So lesson 2 today that we can draw from our work was that resilient health systems matter. And this is an area very near and dear to my heart. So resilient health systems are, it refers to an institution's and health actors' capacity to prepare for, recover from, and absorb shocks while maintaining those core functions of a health system and serving the ongoing as well as the acute needs for care within communities. So we saw in COVID-19 that many health systems were not as resilient as we thought they would be to these shocks. But if I also think about TB, I think that our health systems also aren't resilient enough to outbreaks of known diseases, let alone emerging infectious threats. And often health systems will have resilience in some areas, but not across the health system and not for all people. So really pushing towards this comprehensive view of resilience that reaches all corners of the health system and all communities. So for COVID, we explored some key dimensions of health systems resilience. And we really, when we were conceptualizing how we approached this, we had communities at the core. We then considered the WHO health systems building blocks as the key aspects of health systems. And of course, COVID emphasized the importance of multi-sectoral approaches. So we layered on this lens of looking at collaborations across sectors when we're considering what makes a health system resilient. And then of course, the pandemic really underscored that health equity and good health outcomes are essential goals of a health system, which I think for many of us was something we already very much felt and knew. So by analyzing these 28 national responses, we then identified 4 key activities that were taken at the health system level by effective responses. And that was effective responses during that slice of time. So countries that were doing well during that point in time, they had activated comprehensive responses early in the pandemic. They had then adapted health system capacity to respond. They while doing so, they had preserved those key health system functions and resources and kept some capacity to be able to meet the ongoing needs of their communities. And they took active efforts to reduce vulnerability within communities. So meanwhile, these systems were monitoring and evaluating the response. There was built-in mechanisms for learning and adjusting approaches as they went, so allowing for a bit of flexibility based on the emerging situation. So some considerations for public-private health systems resilience is, again, ensuring that private care providers are linked not only to the public health response, but also to the health systems response. So we understand the full picture, both epidemiologically and from a health resources perspective. So our analysis found that the private sector was drawn on in many health systems to bolster health system capacity. And that was done through novel partnerships and funding mechanisms between the public and private. And this was often used to expand ICU capacity or hospital bed capacity, in some cases to build makeshift hospitals or areas for care. And as well as drawing on the private health sector workforce was something frequently seen during COVID-19. So the final lesson I'm going to lead with today is that there's a need for transformation in how we prepare for and respond to pandemics. So from our analysis, we found some barriers to early national responses, and those were responses that devalued the response or hadn't invested in public health and health systems prior to the pandemic. They had denied the need to respond and maybe didn't take the threat of an emerging pandemic seriously at the start. That had delayed the response and took this wait and see approach, which I think was characterized a lot of responses early in the pandemic, was waiting and see for more data or more information. And those that had a culture of distrust of scientific evidence at the highest levels. So those were some key barriers that came out to effective responses. Whereas facilitators of effective responses are those responses that valued partnership and coordination, worked to develop capacities and support the health workforce as the pandemic was ongoing, and those that strengthened trust and ensured people had both the social and financial protection measures they needed to adhere to the public health and social measures that were then required of them during the pandemic. So when thinking ahead, we can see that pandemic preparedness and response, we can think of it kind of like an iceberg. And I know the iceberg metaphor doesn't often pop up in public health, but I like to bring it along for the ride. So if we think of it, visible on the ocean are areas where we can react to what we see. So the tip of the iceberg is those immediate threats that require us to use the tools that we have at hand. So our public health interventions, doing these proactive precautionary responses because we can see what's coming. But then just below the surface, there's this greater risk, this wider risk that we may not see. And this requires us to draw on systems and think a little bit beyond the borders of health. So of course, to address some of these risks that we might not be able to see coming, we need resilient health systems, we need universal health coverage and people-centered approaches. But we also need to think about the socioeconomic supports that might be needed if we have to enact public health and social measures again. We also have to think about the multidisciplinary research that is needed to better understand how to respond to these crises and emerging threats. And then deep, like the whole picture, it goes much deeper. And so when we truly want to think about preparing for pandemic threats, it will require a very deep transformation. So that's about shifting societal values, thinking of new approaches to leadership, and creating healthy cities and healthy societies where not only is the risk of a pandemic lessened, but outbreaks can be halted quickly and effectively because we understand that there are deeper roots to the pandemics that we face today and deeper roots to these wicked problems in public health. So that's thinking about building equitable societies and shifting mindsets towards true preparedness and thinking of these whole of society and whole of government approaches when it comes to preparing for health emergencies and, as we know, addressing the societal and economic challenges that really underpin a lot of the diseases that we face today. So I'll leave you with our iceberg of transformation. These are the sources that I drew from, happy to share. And thanks again for letting me be a part of this panel.
Thank you so much, Victoria, for sharing those lessons with us. I do know that like I said earlier, it's inspired some of our own work and reflections around pandemic preparedness and how it impacts TB systems. So now I'll turn over to Laura Jane to talk to us about some of the lessons from the COVID study from Indonesia, India, and Nigeria. So over to you, LJ.
Thank you, Charity. It's a pleasure to be with everyone today. I'm going to share my slides here. As Charity mentioned, I've had opportunity to be connected to the COVID project, and I'll talk a little bit more about the specific work that I'm going to be presenting on today. But as Charity mentioned, my name is Laura Jane Brubaker, and I'm a postdoctoral fellow and have adjunct status in the School of Public Health Sciences at the University of Waterloo in Canada. And so today, I'm going to be focusing a little bit more on three countries that were part of this COVID study. So Indonesia, India, and Nigeria, and a smaller slice of a much bigger project. And so before I get started presenting some of our data, I just want to acknowledge that I'm presenting on behalf of a much larger team. And so I've noted co-authors who are on a manuscript that we've drafted that's associated with what I'll be presenting on today. And also that there are many others who have been connected to the project in a variety of ways. And I want to acknowledge staff in these countries that were involved in data collection, as well as the interview participants who were policymakers in these countries. And I'll speak a little bit more about our data collection approach. And also that funding for this study was from the Bill and Melinda Gates Foundation. So Charity introduced this project briefly, but the COVID study is the COVID-19 effect on TB in the private sector study. And so this study focused on India, Indonesia, and Nigeria, which I'm sure many of you on this call are aware, where a lot of initial care seeking for TB happens in the private sector, and that these are high TB burden countries. And the objective of the broader study was looking at the impact of the COVID-19 pandemic on the private sector specifically. And we wanted to, with the data that I'm going to present, apply a lens of pandemic preparedness and health systems resilience to that data as well, as we found that as policymakers were discussing strategies or approaches to respond to the pandemic and to facilitate continuity of TB care, they were often talking about these building blocks of resilient health systems, as Victoria spoke to as well. And so we wanted to consolidate some of those lessons learned for future pandemic preparedness. So between May and November of 2021, there were 33 interviews conducted, so 11 in each of the three study countries. And these were conducted with policymakers and stakeholders at different levels or scales of government, and involved in the TB response and involved in the broader COVID-19 response as well. And so we conducted these interviews, and then we looked at, this is what Victoria presented on as well, but we pulled from the building blocks, WHO building blocks in the green section here, the various domains of resilient health systems, and wanted to map some of what policymakers were saying specifically to the governance and financing domain, the health workforce and health service delivery domains, which we collapsed and considered together for this purpose, for this study. We looked at public health functions and that at medical products and technologies as well. And then in that blue ring that Victoria spoke to as well, in terms of multi-sectoral approaches, we wanted to also zone in a little bit more on how public and private collaboration was occurring in the context of COVID-19 with respect to TB service delivery. So I'm going to zoom in on each of these sections specifically, but I just want to give you a sense of this whole picture here, this figure in the middle of the slide. And this is a figure that we developed based on those building block domains. And so what I've done is created these three columns that map to the three study countries, India, Indonesia, and Nigeria, and each of the strategies strategies or specific responses that were noted are on the left side of the diagram, and then policymakers from each of the countries that made note of those approaches are shaded in the columns beside. But to start with, governance and financing is the first kind of component that I wanted to speak to a little bit more. And so what we found was in a number of countries, there was discussion of a need to incentivize the private sector to quote unquote run government programs. And so for example, there was discussion that within COVID-19, there were increased operational expenses for private providers, for instance, to purchase and to distribute PPE, but that there wasn't necessarily public sector support to do so. And so a need to incentivize with financial incentives or infrastructure tools to run government programs, or to ensure that these programs are being facilitated within the private sector. Within India, policymakers talked about the role of PPSAs in partnering with the NTP to implement a joint strategy for TB that was across sectors and across states in India. We saw in terms of governance and strategy in Nigeria, policymakers noted that there was formal structure for integrating the TB and COVID-19 response across public and private sectors. And so this was in the state of Kano, where there was a specific TB COVID-19 consolidated COVID-19 response team. And so that was a formal integration of the TB and COVID-19 response that was seen as effective. Across all countries, there was mention of an all-of-government approach to COVID-19, at least in the slice of time that this study was conducted in, where there was really a multi-sectoral and a community-engaged approach to the COVID-19 pandemic that could be leveraged to support TB care moving forward. And then within a few countries, there was discussion of how the networks of NGOs, as well as of private provider professional associations, were seen as these sort of nodes where these networks ended up being a liaison or a bridge to the various people in those networks, where that was seen as a way to facilitate public-private coordination. So for instance, in some countries, there was standardizing of COVID-19 protocols where information could be disseminated through the networks of these private provider professional associations or NGOs. And that was seen as an effective tool for a coordinated response. So moving to the health workforce and health service delivery. So as has been mentioned already, across all countries, really policymakers spoke to the crucial role of the private sector and also of the third sector, of the voluntary sector of NGOs, in really filling public sector gaps in access to TB care, especially in lockdowns. And that in some countries, there was this really effective reallocation of the health workforce across public and private sectors. In Indonesia, there was discussion of a centralized system of mapping and distributing the health workforce across the public sector in COVID in order to facilitate this continuity of care for TB patients. In India, the NTP had a telephone follow-up and door-to-door delivery of TB treatment to ensure continuity of care. Nigeria had a policy where there could be public sector referral of TB patients to private hospitals to ensure that continuity of care, and that was described as being an effective approach. And really, there was discussion across countries that while there was increased in COVID, there was increased overall communication between the public and private health sectors, but still a need for enhanced reporting mechanisms between the two, and also synchronization of data and systems to ensure that data is synchronized to reduce patient loss to follow up when there is referral and movement of patients from public to private sectors or vice versa. In terms of public health functions, there were a variety of, speaking to those core public health functions that Victoria mentioned as well, there was in India, decentralizing of lab infrastructure and some enhanced diagnostic tools that were developed for COVID or utilized in COVID, for instance, AI-assisted imaging, and really that could be, these tools could be leveraged now to support TB care. In a number of countries, there was discussion of the need now for a pandemic response package. So for instance, having standardized communication guidelines for how to manage TB effectively within a pandemic, and that this could be disseminated through central TB programs, and that there's a need for that type of response to be coordinated and consistent across the public and private sectors, and that by having some form of response package built and these communication guidelines for TB management built into this response package, that could be a tool to enhance clarity and consistency across sectors. In Indonesia, policymakers spoke to how there was increased private sector engagement and public-private collaboration for implementing the national COVID-19 vaccination strategy and for distributing PPE, and how might there be lessons learned from that that could be translated into TB services. And then in Nigeria, policymakers spoke to this, to having an integrated disease surveillance system that was across both public and private facilities at the local government level, and that could be now a tool both for future pandemic preparedness and for supporting TB management moving forward. And finally, with this domain of medical products and technologies, it's also been mentioned already that digital health innovation really was scaled up and utilized in COVID. And we noticed that across all three study countries as well. And so mHealth, or mobile health tool, was really an effective tool to facilitate treatment continuity across the public and private sectors. For instance, tools that enabled remote prescription renewal for TB treatments. There was a note around a need to invest in and to scale up IT infrastructure that can help to facilitate treatment adherence tools in pandemics, but also that alongside, the scale up of these tools, just how necessary training is in order for these tools to be effective. So training both on the patient end as well as on the provider end in terms of how to best and effectively use these tools. There was mention in Indonesia around the need for regulatory change. So within the private sector, that these telemedicine consults, which we saw a lot in COVID-19, need to be recognized as visits and funded as such within the private sector. And then finally, really across countries, implementation of digital tools for virtual consultations that were used to limit community transmission of COVID-19, but that the uptake of these tools could be used to support TB services moving forward. And an example in Nigeria being EcoTelemed as one of these digital tools that we saw being used in COVID as well. In terms of public-private health sector engagement, we saw in policymakers in all three of these countries really drove home that the private sector played a crucial role in TB care during COVID, and that by strengthening public-private engagement, there's a variety of functions or purposes that can serve. And so for one thing, augmenting the public health system and filling gaps in TB service delivery through allocation of the workforce across sectors, that by strength and engagement, there can be clarity and consistency of guidelines and policy and training, and that this can be effective to ensure continuity of care in a pandemic across public and private sectors. And that this strengthened public-private collaboration also opens up these expanded distribution networks for things like PPE, for TB medications, for vaccines through private facilities. And that we saw evidence of this already in COVID-19 across the three study countries, but that by continued strengthening of collaboration, we can utilize and sort of leverage networks across sectors to ensure and to bolster TB care. I want to end with a quote from a policymaker in India who really spoke about a political commitment that they saw in their early stages of COVID-19 that was multi-sectoral, and it was community engaged, and it was collaborative, and really driving home. And I'll just read what they quoted here, that the technical support agencies, the PPSAs, the civil society partners, the community partners, all of them joined hands to give a response to COVID. And if we can do that all of government approach for COVID, then we can do that for TB as well. And that's what we're going forward with. And so hopefully there've been some insights that I've shared from our study in these 3 countries, and really happy to to continue the conversation. And I'll just point to a preprint that we've published with these findings. And so this the DOI, the link is at the top there. And so we have the paper is currently under review as well, but you'll be able to read the current preprint version as well. And so with that, I'll just note that I've left my email on the slide there as well, and happy to continue the conversation. So thank you for the opportunity to be part of this panel.
Thank you very much, Laura Jane, for sharing these lessons from the COVID study. I think the study also agrees with a lot of other studies that really showed, particularly in high burden TB countries, where a majority of the population seek care first in the private sector. We saw the pandemic really galvanizing the partnership between the public and the private sector, where it was almost before the pandemic, it was almost like they were just tolerating each other. During the pandemic, because of the existential crisis that the whole world was in, we saw the public sector really acknowledging and leaning on the private sector to fill the gap and to ensure that other diseases were not dropped along the way. So this is one of the lessons that we found from the COVID study from different aspects, even in addition to what LJ shared. And so I would like to bring in some of the country on the ground experts to discuss what they saw practically during the pandemic, and how they engaged, how there was an engagement between the public and the private sector. So I'll start with Obioma. Obioma, over to you to share some lessons from Nigeria.
Okay, thank you, Charity. I will just use a slide to guide my points. So I'm Dr. Bioma Chijoka Kaniro. I work in the National TB Program, where I manage the monitoring and evaluation units. And I was there through the pandemic, so I think I can give an account of what happened then. So just introductory, the fact that in Nigeria, the PPM aspect became very important to us, because looking at the statistics stated that 60% of the population in the country assessed came in the PPM facility. And the fact that there was also a mandate to ensure that we leverage on the PPM in terms of galvanizing with whatever they have done in terms of infectious disease in the country. So it was important to us to ensure that we leverage on whatever network they have to at least get contribution of TB patients from this sector. So in 2018, we had done some country tour visits, and we tried to look at the strategy of PPM, why it's working in one country, why it's not working in another country, and the gap we have. So we discovered that one of the things was that we as government, we may need an intermediary organization to help us to broker this agreement between the private sector and the government. So by that, we had an intermediary organization that helped us in engagement. And secondly, we also identified the fact that we should ensure that every engagement with each of the private organization is unique, is based on what exactly they want to commit into and what they feel comfortable to do. So based on it, we're able to divide the workflow. And from the workflow, we're also able to kind of arrange the private sector such that some become just identification and referral, and some will take up the other parts of the TB process. So looking into all this, we're able to also go into the typology of the private sector. And by then, there was a great move into the community aspect of this PPM services, because the patent medical vendors, the community pharmacies, they were all important to also be engaged, because whatever happens in the country, you see that when you go up and north, you see that a lot more people, their care behavior, they will move first to these people in the community before even getting to the facility. So looking at the scenario in our country, we knew that that was just the best thing for us to do, to move where the people move. And based on that, we're able to create this aspect of the community in which these private providers were also engaged in the program to identify and refer. So we had done all this, stabilized it in 2019, and in 2020 we had the pandemic struck. And when it struck, it came with several measures which also would have affected the program so much, especially the aspect of lockdown. There was no transportation, there was physical and social distancing, and that's on one part. But the second part was the fact, the fear it caused on people, the fact that the symptom of COVID seemed to be similar to that of TB. So it even created a gap where we were not having a lot of presumptive come up to the health facility. So we just discovered that one of the things that happened was that they had trust to these private providers, PPM providers within the community, who they have built their life around all these years. So there was a movement to them. So the patent medicine vendors, the community pharmacies, the TBAs were having lots of this presumptive coming to them, but because they were prior engaged and they have already been formed as spokes, it was easy. They could, because the TB in Nigeria, the specimen move, not the patients. So these particular people already have formed spokes, so they were able to also channel this specimen to the facilities where they were actually avoiding to go to. So by that, we saw that initially, at the initial part of the lockdown, there was a big dip in the number of our presumptive were accessing our molecular platforms for diagnosis, but gradually started improving, especially with all this hop and spoke movement that was going on. So the referral went on, and we were able to have this presumptive who become cases that were all placed on treatment. But there were other measures we did on the national which helped. The fact that we could help generate a letter signed from the highest part of the government to allow essential staff to move around in lockdown. So by then, our specimen referral or movement was going on. Then all the virtual meetings were set up across the different zones to ensure that the technical help that was required was on. Then we're also able to invest in PPEs so that those who are even working in the communities, and we produced SOPs for them. And those SOPs were things that could help them, like non-pharmaceutical measures of protection in terms of TB service delivery. So together with the PPS is provided, they were comfortable to continue their work in the community. And we just made sure that all the consumables were available within their reach. So unlike our policy to supply 3 monthly, like medicines and the other consumables to the stores, we supplied as much as 6 months at once, and also ensure that we had most of the facility, to the facilities now, not to the stores, to the facilities, they had as much as 6 months within the facilities. And then in the stores, we now had as much as 1 year, because we don't know how much the movements, how early the movements would also start up. So all this, with all the infection prevention and control measures we put in place, helped us to ensure that whatever happened in the community, that we had enough consumables. We had these private providers who were providing. We also had the other community healthcare workers who could also help us to link, all working at the same time. So you could see that if you look at this data quarterly arranged, you see that 2020 had the most patients coming from the private sector compared to other years. So you can see in 2019, in 2018, the number of patients that came in Q1, the number in Q2, the number in Q3. Then you compare it with the same thing for 2019 and 2020. You will see that irrespective of the fact that 2020, there was lockdown and all the measures, that we still had more cases coming in from the private sector. So at the end of that 2020, we had increased as a country by 15%, growing from 120,000 to about 138,000. So we added about 18,000 cases. And if you look out carefully, you will see that those 18,000 cases came from the private sector itself, because from 2019 to 2020, the private sector added about 18,000 cases, even though it increased by 108%. So it was just sure that if not for the engagement we had with the private sector, that probably the country may not have had this 18,000 additional cases and may not have closed the year with a 15% increase. So with that, we know as a country that community resilience is very important, and having them at the center of the table is important. I like the diagram the earlier presenter showed us, where the community is at the end. And in the aspect of system building, you know, it's all about the people in and also the people who are working around the blocks. But the most important thing is how resilient we make the center. So the direction in the community is which is also one of the things we're doing now as a country, is to ensure that they are not supposed to have the least in terms of capacity. They are not supposed to have the least in terms of resources. So it should be a bottom-up approach. And that's what we are doing now, to ensure that we fortify the community and make them resilient and able to switch in case of any emergency, to be able to, you know, like be like a shock absorber for us at the country, for anything at the lower level, knowing that these patients are with them, the presumptive are with them, and the contacts who we also need to put on TPT are with them. So we are going full blown in the country now. Presently, we have about 30% of our private facilities engaged. So we're going towards 100%. And the mechanism of our funding this year has made it such that every state in this country will be able to engage almost all the private providers in their state. We have mapped all of them, and we've been able to build targets based on it, compared to between now and 2026 and what we want to see. So it's now feasible for us to upscale, and the fact that we have a full section on private sector in a national strategic plan, which is also helping us to monitor exactly all the indicators we have put in, both the process indicators, every kind of indicator that will help us to ensure that we achieve what our goal is for the private sector in 2026. So presently, we know that building around the community will help us in sustainability. So the path to sustainability for us is ensuring that these private facilities, especially those that are closest to the people, are in most of all closest to the program in terms of improving their capacity, ensuring that they are updated with the latest approach in program process and implementation, and also ensuring that they are involved with us in monitoring patients for a better outcome. Thank you so much.
Thank you very much, Obioma. I thank you for reminding us that Nigeria is one of the outliers during the pandemic in terms of the impact on notifications. While most other countries saw a huge dip, Nigeria actually recorded slightly more notifications than the previous year. And the reason for this is what Obioma shared, that before then, Nigeria began to realize that the missing link for getting the missing TB cases was engaging with the private providers. And so they began to engage with them. And it's really reassuring to hear that there's even more there are more plans underway to make sure that all private providers in the country are engaged for TB. This is very, very reassuring to hear. So thank you for sharing that. Now we'll move over to Vaishali to share lessons from India on COVID pandemic and private sector TB care.
Good evening, everyone. Pleasure to be a part of this group and the webinar. I have not prepared a presentation, but I have written down the points which I had to discuss today. So my understanding and my experience of working on ground with Doctors for You, the organization that I come from past 11 years. So I would want to give you a small journey, how it started and how today we are placed. So when I had taken up public health as a profession and started working in Doctors for You, that was back in 2013-14. So that time the scenario was very different. When we had to go meet the policymakers, it was very different kind of a scenario where we were to come, what to come, those kind of things. But once COVID struck, I would say that real partnerships with the government is what started after COVID. So, we were invited for multiple war room discussions where we used to sit with the government policymakers, discuss what are the way forwards and what are the strategies that can be done, and local inputs from the local organization like ours were taken, and then accordingly those strategies were tweaked and we were asked to implement those. So that is one, I think, changing game was there during this whole what we ensured during this time is that, first of all, whatever public health programs were there apart from COVID, we kind of in the very first few weeks only had understood that although COVID was important that time, but there were multiple things that India was struggling with. So if I have to particularly give context of the urban slums, immunization was with the very low, the pregnant mothers getting their USG was not happening. So there were multiple things that was not happening during the first 3 months, and that is a time when we realized and we wanted to communicate. We took up multiple activities where we communicated to the private doctors, including the the community, where we made them understood that apart from COVID, the other things are also completely important, and we really need to focus on those things as well. And with respect to the COVID pandemic, when Doctors for You started working, so we based organization where we provide medical services in the disaster hit zones, and so we were kind of well versed and experienced with setting up of multiple makeshift hospitals within 28 to 48 hours. So we had that kind of experience, and that is what we leveraged for our COVID pandemic. And we used to the way we used to do our strategies is that within, like, say, first 24 to 48 hours, we would establish the dialogue with the municipal corporations at the local level, and accordingly then design strategies and start working on ground. We majorly had taken up the training of the doctors and the nurses and also the frontline workers who will implement who will either take care in the hospital or do the test, trace, treat in the community. So that is what we had undertaken. For the tuberculosis bit of it, Doctors for You is one of the agencies that has in fact, in also the last year, we had the highest number of private TB notifications in the country. So we only have almost 170,000 patients. The team which is working on ground for Doctors for You has notified for the TB patients. So that is the kind of numbers that we've been able to do. But of course, it was a gradual increase from the time the COVID happened, and then gradually we are at this peak right now. So when we during the COVID pandemic time, what we used to do is that we used to motivate the doctors to uptake the telemedicine for consultation, so as to ensure that the follow-ups of these TB patients are done on a regular basis. We also did strategies so that we could improve or not delay the TAT for the lab investigations, and also that we had ensured drug delivery of the patients are done at their home, at their doorstep. So that is what we used to do. And so these were a few of the activities. And what had happened is that during COVID, many people had lost their jobs because many of the companies had laid off people. So many of the people who were there in the slums had taken up things like selling of vegetables or driving an auto rickshaw so that they could support their family. And when we used to counsel them that you shouldn't be moving out because it's a lockdown. So we remember coming across experiences where it was said that even if I am exposed to an infection and probably I may die, but at least my family of 5 to 7 can at least survive if I am coming out. So those were those difficult times where I remember all of us working on ground. So it was very difficult that time. So what we leveraged is that we tried to take up such stuff into our program. And we that kind of established a local trust and connect with the community. And because of that, we were able to kind of track cases earlier and help them to be shifted to the government hospital. So that really worked for ourselves. And also we took up people who used to work, the shopkeepers in the local shops, and also the rickshaw drivers to kind of, work as policemen. Like they used to see who all are coming from, outside locations, and we used to try to trace their houses. So that is the kind of strategies that we had used. And also, because Doctors for You is an NGO, and we majorly have our support from many CSR partners. So during COVID, all of the funding was based around COVID. So that kind of helped us to support a lot of spaces, like including infrastructure, PPE kits, and medicines, etc. So that really helped us to support the local government as well as the local communities there. So yeah, that is the kind of experience I would want to share overall. So if there are any questions, I'm happy to take them.
Thank you, Vaishali, for sharing some of the lessons. It's good to see how, your organization and the country as a whole made attempts to bring services closer to the patients by just ensuring that, even though there was lockdown and there was all of these things, private providers were engaged, and a lot of efforts was made to make sure that patients didn't suffer. I see that, after the initial shock, the country adjusted very well, and the notifications and treatment coverage are now tracking in the right direction. So that is just to show the kind of resilience that exists in the country. So for now, thank you to all the panelists for all that you've shared. We'll now move on to the question and answer section. So if you have any questions, our attendees will ask that you drop them in the chat, or and then we can take them as we go. Right, so please send in your questions now as we begin to discuss some. I have a couple of questions while we wait for some attendees to drop their questions. But I wanted to find out, what are some processes and systems, for example, in TB care that support private providers? And this is really for Obioma and Vaishali. Like, what are some of the systems now that are in place that, at the National TB Program, for example, that support private providers? And how long-lasting would you say they are? Like, now that we're at 4 years in, do you think that these services are here to stay? These systems that the public sector has put in place, are they here to stay to support private providers for TB care?
Okay, thank you for the question.
I'll take this question first.
Yeah.
So,
okay.
Okay, thank you. Yeah. So, when PPSA started, it was basically a pilot that came in India, and it was well implemented. And we've seen that PPSA right now is working in more than 12 to 13 states in India, and a lot of improvement in the private sector notification. In fact, this last year, 2023, it was the highest amongst all these years. So we are seeing a big is that the doctors are actually interested in notifying the cases. There is no doubt on that. And secondly, it is not merely the 500 rupees incentives that the government is giving. It's not really that. They also want to do their bit and part of, being a responsible medical professional, and they want to do it. The only thing that they find annoying is the kind of, the NICSHA portal. Then you have to upload the data. There are multiple things in that. So that is what they find it, annoying. The rest part of it, they are absolutely loving to come on board with the government and give the patients free treatment, give them free diagnostics. Everything is good. So only thing is the documentation part. But yes, when I compare myself working on TB 7-8 years back and now, I think the NICSHA portal is the portal which helps all the information of the patients. It is it's one of the most beautiful portals, I would say. The reason being that any person who's working in TB across the country just needs to have all the history related to the patient is there. So that is something very beautiful, where the exact patient pathway from where it was diagnosed, which day, what sample, which doctor, which city, which day, everything is there on one single click. So that is something very beautifully which has come up. So in case tomorrow PPSAs were to, go away, probably 5 years, 10 years down the line, then something, maybe some system wherein this nick check can be made so easy that any doctor or any attendant at the private facility can directly add on to these details, and then we can, kind of do, have the details. So that will be one very good thing. Secondly, with respect to the DRTB aspect, in fact, like, this year we received the global funding for DRTB bit, in which we are just trying to create a similar.
You're breaking up a little bit, Vishali. Okay.
PPA now for the hospitals trained to give the treatment for DRTB. Okay.
Yeah, you were breaking up a little bit, Vishali, but thank you for that response. Obioma, do you have something that you want to add?
Okay, yes. For us in Nigeria, there are some systems we've been able to put in place to help out. Like I initially said, it was a lot of trial and error for us at the initial time before finally we got some things working, but it's still a work in progress and a lot of lessons learned, which is also helping us to infuse back into the system. So first of all, in the program, we have a PPM unit and a focal person, and what they do is that they kind of liaise with the intermediary organization and also to look into daily what happens around the PPM to stand out in terms of being a focal person for the daily, so that we really don't want any ball to drop. So we needed like consistent and focused attention on it. So, and we also had to bring up the aspect of a technical team that's kind of looking to what has happened within the PPM. And within that, that's where we look at the data system and try to make informed decisions from whatever we see happening around within the PPM. And that's just for us to create, knowing that the engagement, we had to do it from a third party. So this is how we are hands-on to ensure that we follow up with what is happening and get a lot of feedbacks, and also have points of conflict or resolution of any kind of thing, or even trying to create very like an encouraging environment for them. So the steering committee was also instituted, which is a committee that has different, like across the PPM, we have the private providers, private for-profit, faith-based, they're all part of it. Faith-based from different religious angles. We have the patent medical vendors, community pharmacies, and also their regulatory bodies. They all form part of this steering committee. So they are there together with the government, with the non-governmental organizations in this. And this is where major decisions are made. And all these are for us to ensure that we draw sustainability in what we are doing in the private sector, and to give everybody, like, have kind of ownership, and also create responsibility for each and every one of them to know that this is the part you're playing, and it's not about just being part of this, but also you represent a particular community and you're here to speak for them. So the reason why we have all this is because we need to create an enabling environment, and these places where we have interaction with them is one of the things that's helping us to create an enabling environment. So at every point in time, we know what exactly we should do to help them out, especially as government. Sometimes it might just be making like bold policies to help them around there. And is also why we were able to develop the PPM guideline. We have a specific PPM guideline that looks into different aspects of what should be done in the PPM. And that's where we even describe the models, the workflow and all that. And most especially, that is also where we fixed in the kind of MOU that different private providers can sign. And for us being government and having it in guidelines shows a backing to the intermediary organizations that are involved in this. So it means that they are not on their own. They have backing to go on to do this. So those policies and things we bring around the table also help us in ensuring sustainability in this. Then finally, we're able to get the highest health council in the country to help pronounce for mandatory reports from the private provider. So it means that every private provider is mandated to report on TB cases. It's still work in progress. It's not like we've had it 100%, but it's still us still trying to push to ensure that we have this working. But I also must add the fact that in distribution of platforms, especially the molecular platforms, we don't leave the private sector behind. So we ensure that we are able to distribute into standalone labs on some private facilities that have the capacity to do this. So presently, with the molecular platform, we have almost 100 of them are within the private sector. So you see that at every point in time, we still need to give them consumables. We still need to get a report from them. So that syncing is what is helping to ensure that there's sustainability and that this is not coming, it's not a short-term thing. It really will have a long way to stay in the country. Thank you.
Okay. Thank you. We have a couple of questions here, and I will just read them. And if there's any one of you that wants to respond, that's fine. I won't direct it to anybody in particular. But the question is, how can we measure the impact of the private sector involvement in health and TB systems resilience? Like, how do we measure their impact? And what is the major role played by digital, portal X-ray facilities, for example, and other forms of, of case finding outreaches, right? So what is the role played by digital facilities or mobile X-rays and all that? Then also someone is asking that, PPP models in India are essential for strengthening health systems, particularly TB control and pandemic preparedness. What are the sources of this PPP, and how can someone join in these initiatives? Like if someone is interested in, helping in partnering with the public or the private or in these initiatives, how can they get started?
Yeah. So, first of all, related to the digital X-ray, I would want to mention. So the digital X-ray, we are implementing the program where we are doing active case finding through the digital portable X-rays in few of the locations. So earlier we used to do it through mobile X-ray vans, and now we are doing it through the portable X-ray machine, the camera handheld machines. So we are finding a lot of improvement with respect to the turnaround time, and also to if it's an AI-based portable X-ray, then it's extremely fast reporting, and the samples can be taken then and there. So it's a very improved kind of a system that has been established. So, and the problem with it's small, so you can only take it in a bike with a person. Then it is the two people on a bike having the machine on their back, so it is very convenient. So that can be used. So it's very good. The second question related to the how do you kind of have the private-public partnerships? So in India right now, there are few states which are having in which the public system are directly having the linkages with the private sector. Like, for example, there's a state called Rajasthan where the private sector directly is notifying to the NTP, and they're directly getting an incentive from the system. The second way of doing the partnership is where the PPSC agencies are there in almost 12 states, where the agency will come to and map all the area where all the clinics are present, and accordingly we'll tell the doctors related to the facilities which are available under the PPSA scheme, and accordingly do an MOU with them. So these are the two ways how this is possible. And how can we measure the impact of private sector involvement in health? So the thing is that as it was mentioned during the discussion as well, when there is there's any symptom in the community, if there is any person who's having any symptoms, it is very common that he or she will go to the first nearest facility which is available from their houses, and mostly it will be a facility where they have been visiting for past 10, 12, 15, 30 years. they will always go to that particular doctor first. So that is how we are able to have more number of notification, because all these people who were supposed to only come to public sector for the TB treatment were not being notified. So that is where I think, public, such agencies, PPS agency or the private public partnerships have created so much of impact. And that can be seen in the numbers. When you compare the data for almost last 5 years, you can see a gradual increase in the numbers. So yeah, the impact is seen. Thank you.
Yeah, thank you, Vishali. Anyone else wants to respond rapidly as we round up the webinar and give a chance to the panelists to give their closing remarks?
Okay, so I will just quickly say that for Nigeria, if you have 28% contribution of cases from the private sector, is a lot of numbers if you look at it in absolute, because it's you look at it's almost maybe like 60,000 or that in terms of number is a lot. So you can see that gradually we've been able in the last couple of years to reduce the mortality rate in the country from 64 in 100,000 population to about 40 in 100,000 population. And definitely that there's an impact of this 28% contribution from the private sector in ensuring that we identify them early, place them on treatment, and we have less people dying of TB within the community. So you can feel the impact, especially as the numbers keep increasing. Definitely there are other variables that are being affected within the community. And also you look at the aspect of probably having one person die of TB within a community and all the scenario of events that comes in within the family with that. You see that the impact of private sector can be felt really within the health system in the country. Thank you.
Yeah, thank you, Obioma. As you round up your comments for this webinar, I wanted to ask one final question, like how can governments, international organizations, and everyone really further incentivize the private sector engagement, not just in TB prevention, diagnosis, and treatment, but generally when there are health threats? How can we incentivize, or how can we continue to work to keep this momentum going and ensure that the private sector is incentivized to fill the gap if there is ever a health system shock? So with that, I will give all of you, beautiful panelists, to give your closing remarks, and feel free to comment on any of the questions that have been asked before as we round up.
Okay, so for me in closing, that private sector is it's a profit-oriented venture. So you can't do so much, especially for services where you want universal health coverage, improve access, and reduce out-of-pocket expenditure. If you want to ensure that these indicators come down, you definitely have to incentivize, because every establishment of a private sector, most of them are profit-oriented. And it means that if you don't want the burden on the people, then the government needs to bear the burden. And how do you bear the burden? I know that generally in the health system, in the countrywide, there's a struggle of exactly how the private sector role plays and exactly how this incentivization should be done. But the first step is, which is what we did in the program, is first of all, just do a kind of analysis and know, okay, what is it that is your contribution in terms of what you put in the HR and all that, because you just have to have that and signify it into the smallest kobo cents, then what exactly you can add. It might not be so much, but marginally for them not to lose, or dip into their own pockets, because they are trying also to stay afloat for some of them. So just that cost and ensuring that you buffer up for them to provide these services is very important. So that analysis needs to be done on countrywide level and involving the private sector for the country to have a sustainable private intervention and ensure that the health system is strengthened, layering on the infrastructure that the private sector has been able to put up. Thank you.
Thank you. Yeah.
Maybe I can quickly go in next. Charity, thanks for moderating an excellent session. Just a couple of points to note in response to the questions in terms of monitoring impact. This is something that we've been doing at WHO, regularly collecting data, thanks to all the countries who provide this information, like Nigeria and India here, who this data is really critical if we are to basically not only look at impact but also improving access to care services. And for public-private mix or private sector engagement, with the help of the Bill and Melinda Gates Foundation, we have put over the past 2 years, we've been working on an initiative across 7 high priority countries to get data on public-private mix across the pathway. We used to collect data only on notifications or on the people diagnosed, but now we do have data on other elements like treatment coverage and completion, all the way down to access to preventive treatment, the number of providers in a country. And this is something that needs to be expanded if we are to get really a better understanding of the impact of private sector engagement and the contribution that it can have for strengthening health systems. And this is not just for TB, but across all sectors, and looking at universal access to care. So I would say this, our bottom line, of course, is that no matter where a person with TB accesses care or seeks care, they should be able to access quality care, whether it is the private sector, unengaged public care providers, informal providers. This is why it's important to have them, as Obioma said, around the table, engage with them, work with them, make sure that we can align with their needs. I think some of this was already raised also, and it comes out more from the country presentations from Vaishali and Obioma. You need to make sure that they're not burdened with bureaucratic procedures, all of these sort of things which burden them, but look at them as a partner and facilitate and incentivize their participation. And this doesn't necessarily mean financial incentives, but incentivize them and build ownership that in this overarching health response, including a TB response, that they are key partners and players. So this, I would say, is critical, and we know from the data that we've collected. I showed you some of the data that we collected. There's also the PPM Learning Network. Petra and Joel can perhaps post the link to the work done around COVID-19. And you yourself, Charity, did some fantastic work on these patient pathway analysis, the impact of COVID. All of these, very, very clearly show that private sector has a big role to play and a big contribution to make, especially if they can be leveraged in the response. And we do have the data to prove this. So it's really essential as we look at pandemic preparedness response, taking forward all the commitments that come forward on this area, that private sector is a key player taking this forward. Thank you.
Thank you so much. Any other last comment before Petra or Joel will round up the webinar for us?
Thank you all for such wonderful thoughts and bringing out the importance of public-private partnership and multi-sectoral collaboration. Definitely working together is the way to go forward, and that keeps that is one of the main focuses of the TBPPM Learning Network as well. Special thanks to moderator Charity as well as our team panelists for dedicating their time to present in this webinar, and to all participants for joining us from diverse regions across the globe. I'm going to drop in a few links from the TBPPM Learning Network for getting further details and how you can sign up on the website. And as we conclude this webinar, we will also be launching a poll to gather feedback on the webinar. So if participants could remain a few minutes just to answer the questions on the poll. Okay, so we just have 5 questions. So if you could quickly answer those questions, that would really help us in shaping other upcoming webinars as well. So with that, we come to the end of this webinar. So thank you once again for joining today. And after you've answered the poll, have a great rest of the day. Thank you so much. We're just gonna wait a couple more minutes for participants to answer the poll. And fabulous, thank you so much for staying back a couple of minutes more beyond the time that we had initially planned. And thank you once again. Bye, everyone. Take care.
Thank you, everyone. Bye.
Bye.
Yeah,
Bye.
bye.
Bye-bye.
Thank you, everyone.
Thank you.
Bye. Bye.